as I was saying, welcome to this first panel discussion of ICPLP. Professor Di Pino from University Campus Biomedico of di Roma and Professor Angelo Maravita from University Milano di Bicocca have kindly agreed to moderate this session. So we have asked all the speakers, all the invited speakers to join these sessions, and there will be some speakers online as well. Now they will all start by raising a point each that they want to discuss, and then we will open the session for questions, for all the questions that have been gathered during the day. So welcome all.
Thank you. So I guess to break the ice, I can start. On practical matters, I'm interested about your opinion on the definition of phantom limb pain, and if we should start calling neuroma pain rather than phantom limb pain, and this idea of defining phantom limb pain based on the perceived location. And I guess this is more for the clinicians, really. Happy with academic exercises, but I want to get a bit of the practical stuff. Feel free to.
So I personally believe that everything has been lumped together as phantom pain, but I think that there are different etiologies, as I alluded to earlier in my talk, because I would say that if you have a sensation of like a frozen limb that you can't move, I think that something different is going on there in terms of the perception than if you're perceiving just like burning dysesthetic pain or like electric shock-like sensations.
But I guess my question was more related. Will it be useful to make a distinction when we name these pains, to separate neuroma pain from phantom limb pain, just so practitioners can,
Yes, so I think neuroma pain is very distinct because
right.
If you push on a particular area of your limb, residual limb, right, and you get a trigger of like pain, then you would think that sort of a clinician would say you probably have some sort of neuroma forming there or has already formed there, and that's a surgical target. Whereas this general sort of, the Civil War era in the U.S., sort of like they kept doing, they assumed it was all neuroma, so they kept doing serial amputations, but it didn't really help. So that's the evidence that suggests that it's not simply neuroma alone that's going on. And then now, of course, with all the imaging evidence that Herta, Tamar, sort of you all have done in the past, suggests that, there's more to this whole story of post-amputation sensations and pain. And I think that the areas are actually ripe for further investigation.
Jack, may I ask a question? Because do we have good instruments to really measure a neuroma? Because I can elicit phantom pain from anywhere, and from places where there cannot be a neuroma. So the question is, do those perceptual signs really define a neuroma, or how would you do that?
So I think that it's. So let me clarify. I think it's sort of coupling sort of an actual physical sense, like something that's palpable like a mass would be definitely sort of suggestive of that. But I think also, we don't know like on a molecular level or cellular level, like maybe something is forming, and only when you take it and do pathology on it could you tell definitively yes or no.
So I guess your point, Herta, with my proposed definition will be that it's just very difficult to just say it's the neuroma because a stone pain will elicit refer pain, phantom limb pain. So it's hard to tell what's what. And I guess maybe this will be a question for tomorrow's panel where all the surgeons are present, because I think they have looked at we're going to look at stone pain as and what happens when we take care of the neuroma. My guess will be that it will be improved. But the main reason for discussing the definition was that if there is a clear neuroma that you put a socket and the patient complains and so on, anything else that we do with other treatments will be a bit futile because the neuroma is there. So if that's not treated, and I'm not entirely sure that all physicians and therapists and so on are aware that if they have a patient that comes for, say, mirror therapy, and they have a clear neuroma, it will make sense to refer them to the surgeon and say, well, this has to be taken care of.
Can I intervene? Okay. So I think that there is knowledge about the neuroma that can trigger phantom limb pain, also because this is an old story. So, of course, the neuroma pain can overlap with phantom limb pain. So in some patients, you can find both, but of course, they are not the same entity. And you clearly see it in patient. So I think Professor Marking raised the hand. Maybe she wants to intervene.
Yeah, I think at this stage it would be we're not ready to make this dissociation for technical and for conceptual reasons. So technically, just because you can't identify a peripheral origin doesn't mean that it is not peripherally driven. This is just an observation fallacy, and we know about microneuromas. We know about other peripheral contributors such as dorsal ganglion. There's lots of potential triggers that are peripheral that are very, very difficult for us to pinpoint and relate to similar mechanisms as neuromas. But then on the other hand, pain is not just whatever the periphery is feeding to us. I think we all agree on that. So there's very potent modulators, either positive and negative, so that given the same peripheral contribution, two patients would have very different responses. And we shouldn't shy away from that. The fact that someone has peripherally driven neuroma doesn't mean that we shouldn't give them TDCS, because sometimes neuromas are not so easy to treat, and because sometimes central mechanisms might be more powerful.
But I'm not following your argument here. What I'm saying is that if there is a neuroma, the neuroma should be treated. I'm not saying that they should not be able to have other treatments. What I'm saying that other treatments will be rather futile, because if you go and push the neuroma when you put the socket, then you will experience pain. There is no way you can do TDCS and eliminate all perception from nociceptive input coming from a neuroma.
So, this is obviously, an exaggeration, but I stand behind what I say, because first of all, not all neuromas are so easy to treat. Not all patients respond well to neuroma treatment.
Well, but that's a different conversation.
Sorry, and the second thing, the fact that someone has a neuroma doesn't necessarily mean that they're going to suffer from chronic, lasting pain that is making their lives difficult. So there are other central mechanisms that might be exasperating the same input, and we should be aware of that.
Yeah, but you're missing my point. My point, if listen carefully, I'm saying, if there is an identified neuroma that is painful for the patient, and that's the physicians are aware of that, then they should be referred for treatment of the neuroma. I'm not saying that is the only cause of pain. I'm not saying that.
Sure, this is standard practice.
Well, it is not. It is not. I'm not sure how much clinical experience you have, but it's not a standard practice.
I think professors.
Okay. So yes, Professor.
Can I?
Okay, go ahead, Angelo, and then Professor Cervero raised it at the end.
Oh, sorry. Please go ahead first. No. Well, I just wanted to add a clinical point, because I heard that psychological factors also are very not strong, have no strong effect on phantom limb pain usually, as statistics say. Although I think that pain, especially in chronic patients, I don't know, Professor Tsao maybe has much experience, but in chronic patients, so people who have phantom limb pain for years and years, we have found, doing research using like either TDCS or mirror box, that even in those patients in whom therapy was not effective, then psychological treatment was very effective. And there are some patients for whom psychological treatment is essential. I'm just saying this from a clinical point of view, considering a wide view on chronic pain. No? So this is quite true for many kinds of chronic pain issues, such as headache or whatever. So it's very important that clinicals keep in mind that can be a very strong factor for some patients. Okay, so although of course phantom limb pain is not a psychological entity by itself, but I want to underline this because we were very surprised together also with Nadia Bolognini when we started to treat patients that did not have any effect with any other treatments, and it was quite striking to discover this for us. Maybe you are already very aware of this, but it was very striking.
Well,
Thank you, Anne.
Sorry.
Sorry, go ahead. Go ahead, Max.
No, I just want to say that, I mean, one of the reasons why we want to organize this conference is because I think the information, even in the clinical world on how to treat phantom limb pain and what's going on and things like this is very limited. So in my years of going to prosthetic meetings, I have still encountered surgeons who report cases of treating neuroma pain by just redissecting the neuroma, and then you keep doing that, and the follow-ups are very short. And despite that, it's known that just cutting the neuroma again will not have a long-lasting effect. So one of the things that we wanted to kind of do here was to agree on a few things, and then hopefully do a communication of these things to a wider audience and what the best practices are on the treatment of pain. Giovanni, we have a person in the audience here that you can see that want to ask a question, so I think if you don't mind, we'll let
Sure.
you. Can we get a mic? There is one over there.
So I'm just a simple surgeon, so please bear with me if it's a stupid question, but I would make a point to support your argument, because to have a separation. And the point is that, for example, when you do TMR on a patient, and we also do a lot of sensory renovation, and when you do TMR and you take away the neuroma pain, you necessarily don't take away the phantom limb pain. It can alleviate that, but it doesn't necessarily do that in the same procedure. So I think these are very clinically and from the perspective of treatment, of surgical treatment, very distinct entities. They often overlap. I totally agree with that, and I would never say that it's not peripherally driven, but I think that there is quite, so when you look at the therapeutical chart or flow chart, yeah, you have to go as a clinician, then I think you should separate those entities, being aware of that they have a great overlap. And I think the TMR patients that retain, get rid of all the neuroma pain, but retain their phantom limb pain are the best example of that. Because I think it's the best clinical picture we have of that. They retain all of their phantom limb sensation or pain, getting rid of all the neuroma pain. So this, in my opinion, although it's just few patients I'm aware of, like I did surgery on like 5 or 6, that had exactly that pattern. So neuroma pain gone, phantom limb pain still there. And I think that illustrates that, might make a point for that, statement, yeah.
Right, and immediately after TMR surgery, your phantom pain can get worse before it gets better. So it's consistent with this whole idea, that there's some, I think now sort of my views have changed over the last few years, that I think there's more to be studied in the periphery in terms of how it feeds into the central nervous system, and that it's somehow, it may be much more of a modulator than we have given it credit for in the past.
I wish that this conference goes obsolete in a few years, because all patients are having TMR at the time of amputation, or IPNIs on some surgery, and then phantom limb pain never develops in the first place, and then we don't have to sit here to talk about this, but we'll see how fast we can get that.
So if I can resume this part of the discussion, I think I hope we all agree that phantom limb pain and neuroma pain are not the same thing, that there can be a huge overlap, and that, of course, if you know that there is a neuroma, this should be taken into consideration, while if a patient comes to your attention with phantom limb pain, maybe something that should be investigated is also if he or she has a neuroma. My comment on that is also that having a neuroma does not mean that the neuroma is clinically active. So as neurologists used to say, clinics should drive also the further investigation.
I'll rest here, so I guess we'll go to next speaker who want to bring a point.
Fernando had a question, I think.
Oh,
Fernando?
yes.
Don't you have a question? You raised your hand?
Yes, I did. Yeah.
For a long time.
I'm just listening. It's really a point, a very simple neurobiological point. Every nerve that is sectioned is a neuroma. So let's make that very clear. Every nerve that is damaged or sectioned attempts to regenerate. This is part of neurobiology. And the attempt to regenerate is the neuroma. So in some cases, the attempt to regenerate, if it doesn't have the appropriate target, may produce also connective tissue and other things, and then produce something that you can touch or see. But even if you don't see it or touch it, every section of damaged nerve is a neuroma, is spontaneously active, and is mechanically sensitive. Whether you want to call it neuroma pain or something else, it's for the specialist. But there are no nerves that are sectioned that are not neuromas. That is just simple, basic principle.
I agree, Professor Cervero, but then how we decide when to remove a neuroma, since each cutted nerve has a neuroma? Maybe the clinics should drive our choice, right?
Yes, of course. I mean, it's a completely different thing. That you can see or touch a neuroma is a different thing. That neuroma may be particularly active and is driving the pain of a patient is another thing. But what you cannot see is that you can have an amputee without neuromas. It will have, I mean, those may be active or not active, but every person that has a nerve section has neuroma by definition of neuroma. That's how it is.
May I say a word about the psychological factors, because I don't want to be misunderstood. I'm a psychologist, in fact. And of course, psychological factors are important, also in phantom limb pain. The point I wanted to make is if you compare phantom limb pain patients to other patients like fibromyalgia, chronic pain, they are coping much better on average. There is, of course, always patients where they are traumatized, where there is something special. And they also have less comorbidity with depression, anxiety, and so on. So that there is a difference there. And I also showed that, of course, the prediction of phantom limb pain is possible from pain, anxiety, and depression before the amputation. So that is also a factor that can contribute to phantom limb pain. Just so not to be misunderstood. So psychological factors are always important, but the different patient groups are differently affected by them, I think.
Do you have an idea of why that is, that a person with an amputation will cope better with?
Yeah, I think that in a lot of the musculoskeletal pain problems we see, it's a slowly developing thing that is also rooted in psychological stress-related problems and so on. And so I think the factors early on contributing to this are different, whereas in the amputation you usually have this trauma, and then you kind of have to cope with this event, and you don't have the long history you see in the other pain groups. That's a guess. I don't know, really. But I know it, I see my students, for example, they love to work with phantom limb pain patients, and if they have to deal with back pain and fibromyalgia, they don't like that, because those patients are a lot more complicated. Yeah, and if you have phantom limb pain patient coming back for years who serve as subjects, because they are just in a different psychological state.
Yeah, so something I observe when talking about phantom limb pain around the world is that in some countries, so take Mexico and China, and I'll give my talk, and physicians will come after my talk and say like, oh, that phantom limb pain thing is interesting. My patients don't have it. And then I was like, oh, is it a white people problem or what's happening? So there's a lot of stigma around it, I think, in many countries. And in my experience with many patients, they kind of learn to live with it, and because they're not referred to proper care. And I think that's one of the biggest problems, because many physicians don't know what to do with it, and then they just left to live with it. And I don't think we should be leaving people to live with pain in this age, and you know, again, why these efforts. I want to point out that I also think the psychological effects are important, and that's why I begin my talk by saying there are these mental parts that can make a difference of what you experience, pain or not. And so it is. I think it's becoming more common on pain to have these more comprehensive, holistic kind of treatments where they address psychological things.
I think you do raise an interesting point. It's not clear that the incidence of phantom pain is the same globally. So, I mean, it's possible if you're not Caucasian that your incidence may be completely different, right? I mean, so I think that remains to be studied.
That will be a good point. See, I'm not sure there is. But I mean, there are reports of phantom limb pain in like studies from say, India and different countries in Asia and so on. But the incidence, that will be a different matter. So maybe we can arrange an international study with some of the people that register from different countries.
Not Marshall, Zef Seltzer. Zef Seltzer has data on 5,000 Cambodian amputees, and he has data showing that the phantom limb prevalence there is only 20%, while it's about 80%. Elsewhere, the question is, of course, is it really different, right, or do they report it differently? But they used interviews. They didn't do questionnaires. So at least they made a big effort. And so I really think that's an interesting question. Also, my Chinese collaborators, they always only find patients without phantom limb pain,
right,
which is also interesting.
Moreover, I think it would be very hard to clearly disentangle biological from such sociological factors.
Yeah, I agree.
Yet is the problem that we have, right? So that was one of my points in the beginning of my talk, that there's all these things that play a role that will, in a way, also explain why that many treatments are reported to work, because there's few things that can show a bit of improvement there.
Can I just, sorry.
Sure. No, I was giving the word to you. Okay. Please.
Yeah. There is a very important thing here in terms of the social aspect that has been mentioned about distribution of disease. And please, it's nothing to do with race or ethnicity. So that's a very important thing. There are very few things that are directly related to race or ethnicity. I mean, race is even backward, ethnicity in that way. What it is related to social development. The best correlation of low back pain is with countries that have a good system to produce work treatment, and particularly work relief. So the more support you have not to work, the higher the incidence of low back pain. And this has been shown in many places. In places where there is no support for not working, there's virtually no low back pain because you have to work. And the same thing may happen with other things like that. So the same thing happens, for instance, with the use of opiates, with treatments, there are a myriad of things in which the differences between the developing world and the developed world are greater, and that it is seen on the prevalence of certain diseases.
This is a very important point. Okay.
So just as a very simple kind of anecdote, the incidence of heart attacks in Northern Ireland was at its lowest at the peak of the troubles in Northern Ireland. Okay? So the more bombs and killings and things were in Northern Ireland, the prevalence of heart disease decreased. There you go.
Yeah, this is interesting. So, okay.
I think it's always difficult to ascribe causation, right? So things can be occurring that are truly unrelated. And so that's always something sort of in science, right, that you always have to be aware of. And then the only other thing I would add is in terms of like rehabilitation therapy, I think the best programs are comprehensive ones that address, both the psychological as well as the physical rehabilitation. And having multidisciplinary teams can often mean success for a patient in recovery.
Okay. Max, go ahead.
I will not monopolize the debate, so I'm going to let other people to bring their points. If there's not, then I can, of course.
So
are there any other pressing questions that were addressed to the speakers that you feel you want to bring up?
Eva, is there some interesting questions that we want to bring up? But if you don't, do you have a point, Robin? You wanna?
Yeah, I have a question. When I heard about the different hypotheses from Tama, from Hertha, also from you, I think all research is performed on amputees with phantom limb pain or without phantom limb pain. But considering the importance of movements and the ability to move, should we better compare amputees with phantom limbs and then two groups with phantom limb pain and without phantom limb pain? Would that help to differentiate between the validity of different hypotheses? I know it's very rare, to have amputees with phantom limbs, but without phantom limb pain. But would that help?
I guess it depends what the question is.
About the importance of motor ability,
right, yeah.
And I think this is also important for your hypothesis, for Tamas, but also for yours, Hertha.
So I think there are not very much clearly stated hypotheses, really. I mean, there is the paper of Harris, and there was a hypothesis paper. That's what I've done. But everything else, I don't think there's a paper for the maladaptive plasticity theory. That doesn't even exist in my viewpoint. It's like something people start talking about it, but it's not a thing. I mean, technically, if we take word by word, maladaptive is an undesired, change. Plastic means permanent, and obviously is happening on phantom limb.
No, but my point is, would the research be better, or the results better, if we would compare, or if we would group our participants differently? Maybe there are also other factors as well.
I think down the road we may end up subcategorizing, right, in terms of, but in terms of trying to figure out like what helps one person and why it doesn't help another, right? Because like mirror therapy helps some people but not other people. So what's different about those who it helps versus those that it does not help? Similarly, what sensations do people have? Does that actually like potentially feed into like the psychological side? Like PTSD seems to have been correlated with some of the factors that we were looking at in our patient population. So I think there's more to be studied, and it may be worth further dividing into subcategories the various amputees and phenotyping them better.
Robin, I'm not sure I even understood exactly what you meant. Did you mean to study amputees without a phantom limb per se?
No, this is what we often do. Yeah, we compare participants with phantom limb pain and without phantom limb pain, but these without phantom limb pain don't have phantom limbs. Yeah.
Oh yes, but I never saw an amputee who didn't perceive a phantom.
No, actually,
some people don't.
Except for congenitals, of course, we have that.
But some amputees, when you talk to them, they no longer remember having a limb, right? So that's another subcategory. So most people have a phantom sensation afterwards, saying, I still have a leg or I still have an arm. But some people you talk to, they're like, well, I used to have an arm, but I no longer have it at all.
Exactly. But
I think that group has really not been well characterized in terms of like, why does the memory of the limb fade from memory at some stage in some people, but not everyone either. So that's another.
And often we include participants, I don't know, 3 decades after amputation. And at the moment I perform some studies on lower limb amputees, and there are quite a lot who have no phantom limb.
They don't feel the phantom.
Mm.
You mean they have no phantom limb awareness? But we characterize them if they have phantom limb awareness or not. So it would be easy to see if they are different.
Yeah, but
with arm amputees, in my opinion, it's very rare that they don't have an awareness.
It's not super common. But going back to the psychological aspects, we had a patient who was enrolling into our different trials, and he was afraid of going to the treatment because he has read from one of the papers of Ramachandra that the phantom will disappear, and he liked his phantom. So like, I don't want to go through this because I really like to have my phantom, and it's good for prosthetic control and so on. In our studies, and I think now it's been probably over 100 people that gone through PME. I don't have a single report of somebody that had a phantom disappear after.
Yeah,
if anything, they get
either.
better
Yeah.
at having control. But there are some of the clinicians here that have participated. But I don't phantoms disappearing. No, we haven't heard from that.
I think you see it, but I'm not sure that it really, like, sort of, if you're doing active rehabilitation, right, and somebody has an arm or a leg to work with, prosthetic that is, I suspect that you're likely to incorporate that into body schema in order to, as part of your rehabilitation. So I wonder, if you put somebody who has no awareness of a phantom, you gave them prosthetic, maybe that would actually cause them to have another memory if they have to control something.
So I have a question on the topic. So in my experience, any amputee that perceive the limb and control it quite well does not have pain, while when there is pain, the awareness is not normal, is a distorted limb. So do you agree on that there is this correlation or not?
Well, telescoping and phantom limb pain correlate in our hands about 0.6, 0.7. So there is a high correlation. It's not perfect, so it's not in everybody, but that is true.
And stiffness in the phantom correlates with phantom limb pain.
Inability to move the phantom, like a frozen phantom,
right.
A frozen phantom. Also, yeah.
But maybe I'm really impressed by what you are saying, because in my sample of 200 lower limb amputees, there were about 40 or 45% who state they have no phantom limb. Might there be a difference between lower and upper limb amputees?
Well, you have an extraordinary sample for a great study.
We have online data so far, and we invite them at the moment, but the percentage is very high.
But is it based on questionnaire or on interview? Because I would always prefer an interview to verify that they really understand what you mean.
We do
so
it
if
with
it's interview based, then I think it's valid.
These 200 are online, and it's a questionnaire, but we do the interview when we invite them. Yeah, we will see.
Okay, so
can I ask a quick question?
Sure.
This is coming from the outside. This is for those of you who have big experience dealing with patients. When I was preparing this thing and reading a number of bits in the literature, there is quite a wide, at least in the literature, range of proportion of people who have a phantom limb and who also have pain. So that apparently it would appear that most people have phantom sensations, but only a proportion have pain. And that particular pain is not necessarily like spontaneous pain or something like that, but is consequence of the posture in which the phantom is felt. Is that the case? And can you, Herta and other people, can you just clarify this a bit?
So I think that the frozen limb is a subset of the people experiencing phantom pain, but sort of the older literature suggests, phantom pain goes away with time, but in our surveys, we found that about 50% have pain persisting for years. So it's not like you may be lucky that it goes away after time, but 1 out of 2 has it for years to decades, a few years to decades down the road. So I think that's something to be aware of. That it's that now that research has expanded in this area, that people have been better able to characterize things. Similarly, in the past, it was thought, well, with diabetic peripheral neuropathy, right, you don't sense your leg, and so if you lose the foot due to amputation, you won't have phantom pain, but that's actually not true either. So diabetics do have phantom limb pain after an amputation. So I think it may be, in the past, people just haven't been asking the question, or maybe not asking it correctly to actually detect it.
In our experience, the frozen phantom is, and this is, I should give the word to Dr. Ruffin, because she's done all the work on phantom movement and pain. But in our first clinical trials on patients with chronic intractable phantom limb, they all came with the frozen phantom. It was, we have to get them to start moving their phantom as well. So in my experience, the longest they've been amputated, they tend to have the frozen. And I'll pass the word.
Yeah, indeed, we also found this correlation between time since amputation and the quality of the motor control of the phantom limb. So it seems that with time, they lose this ability to move the phantom limb if they don't train it. So they can forget it. And about the posture, you said, it's true that some patients, they also report that the pain they feel in their phantom limb arises from this aberrant or incongruent posture of the phantom limb pain, sorry. So the phantom limb has a really strange position, completely incongruent with the normal body schema. And so that also, for me, it links with the idea of, we said previously, that there are different kinds of phantom limb pain also coming from different etiologies. And that's, I think, important to investigate, as well as this inter-individual variability, in particular in the responses to different therapies. I think this can be explained by these different types of pain.
Yes, so, well, just, I don't want to anticipate my talk, but we also found in our TDCS study that there is a correlation. We treated all the amputees with chronic phantom limb pain, and we found a strong relation between the analgesic effect of motor cortex stimulation, phantom limb pain relief, and the ability to regain the control of the phantom. So our findings are in the same direction.
Well, I guess that sort of gets at the question of motor control. Like, is it because you're suddenly activating DRG sensors, right, with your motor control, or some sort of peripheral feedback, versus is it an embodiment issue, right? Because now you may have prosthetic use on top of things. So I think that sort of these are all questions that are merit looking into.
Yeah, it may be that your motor cortex is able to generate the command, and so you receive an efferent copy, or that you are able to receive peripheral feedback of the downward output of the motor command. So from the spindle that are remaining in the muscle, or from some relay. Please go ahead, Nadia.
Yes, even both mechanisms together.
Sure.
I mean.
So indeed, I can use this point because there were several questions that highlighted the importance to maintain or not this dichotomy between peripheral and central origin of the phantom limb pain, or sensory and motor trigger of the phantom limb pain. So what do you think about this point? We should maintain a dichotomy, or we should discuss how to integrate them?
I think it's a continuum. I think from a research standpoint, maintaining a dichotomy is helpful because then you can test the hypothesis of how does the periphery contribute, or how does the central nervous system contribute or react, or things like that. So I think it depends on how you want to, or where you're coming from in terms of your perspective.
I agree. Yeah.
So I find myself a bit separated on I suppose the way that I see things, because to me fibers that had free nerve ending fibers that were picking up potential tissue damage and nociception, if those are stimulated, they will produce a experience of pain in the phantom, and that's by definition, as we have it today, phantom limb pain. And that's a clear mechanism. So everything else, it seems to be like I don't necessarily see the separation from the viewpoint that once that's gone, then what is left? So there's the spinal cord changes, I suppose, and then like more stem.
But Max, how do you know it's nociceptive input really that drives the phantom pain? I would rather I can see that clearly with residual limb pain and some that you do have certain inputs, but for the phantom limb pain, I wouldn't be sure.
So I mean, we know from
you know what I mean.
Yeah. So from microneurography and so on, we can so we know they stimulate nociceptors, there will be pain. So I suppose how is it the only one, and there could be other things, and one of my students was pointing out that there could be something related to allodynia that we can really see because there's no phantom, but there's a change on the spinal cord, and that could be a problem.
Because I think most nociceptive pain is with acute pain. As soon as it becomes chronic, you have a really wide variety of mechanisms, and that are not necessarily based on nociceptive input. Like that's why the term nociplastic, I think, was coined.
If I could jump in, I think this is actually quite important to recognize that pain is very heterogeneous, and I was struck in I guess Jack's talk sort of trying to break this down into categories, and I think some of those categories might speak to different origins, right? That the paroxysmal pain is not equivalent. The etiology, the fibers contributing to it, the central versus peripheral contribution is not necessarily going to be equivalent to the crushing pain or the burning pain or the cramping pain. And so I think sort of recognizing that and trying to piece, phenotyping very carefully, and then trying to recognize differential effects of therapy on these different types of pain, or recognizing different onset kinetics, right? I'm always struck by, how slowly some of these pains develop. But if there's differences there, I think that could tell us a lot about what's going on, and recognizing that different types of pain might respond very differently to different interventions and whatnot. So I think that's really important to keep in mind.
Can I just also, sorry.
Sure.
Well, we have to be very careful here, because a pinprick is pain up to a point. And that's sort of lab pain, a pinprick, a little pain, that's a nociceptor, blah, blah. This is what I was trying to say in my talk. Somebody who has phantom limb pain for a year or two or something is a completely different thing. And it's a very complex experience with all sorts, there are cognitive elements, there are social elements, there are all sorts of things. And the final sensation, perception, experience, the final experience of pain is colored by all of these things. So I think it would be against our own interest to say, well, if we activate a neuroma in the periphery, then you have phantom limb pain. That is an extremely simplistic way of looking at it. And this is going back to the reason why the prevalence in different parts of the world may be different, depending on the social the expectations of pain is the most important. If you, before the anesthesia, good old Horatio Nelson that I was mentioning in my talk, he had his limb chopped off without any anesthetic. Now, if you go to your patient now and say you're going to do the same, he will run away. He will think it would be intolerable. He would die. I mean, this is just, and yet millions of people have had bits of their bodies chopped off without anesthetic and they survive. And that was only to do with the expectation. So, whereas it's good to dissect elements to see where sodium channels are involved or the spontaneous activity involved, that's all fine from the point of view of extracting the neurobiological process. The experience of a patient with chronic pain for a number of years is an extremely complicated thing in which, as you mentioned before, cognitive, emotional, psychological, whatever factors you want to say, color 90% of the experience.
Just to clarify, in my talk I mentioned that of course there are different factors, and the pain can be multiple realizable. So I'm not saying that the neuroma pain is the only way. So that can coexist. So the patient after 10 years of amputation that has pain because, say, some central changes or spinal cord or so on, if you stimulate the neuroma, they will still feel pain because of the stimulation of the neuroma. So those things are present. They're not. It's not only one. They can have pain for the different reasons, and even the quality of that pain might be different, right? So their pain when they have the socket and it's pushing the neuroma might be of some sort, and the other one can be different, or it could be the same. So, but those two things can be. Now, if I will be a patient, I would like to exhaust all the potential sources, right? So there are three sources that can be producing pain, and one of them is a neuroma. Well, so that should be addressed. But after that, then there is, there are other things that need to be looked at. So not entirely reductionist.
Okay. So I can use other question from the addressed to the speaker today. For instance, Max, this is a question for you. So you highlighted the not importance of the visual feedback in the phantom limb pain. So I was wondering, phantom limb pain is pretty much a phenomenon that we see in amputees. So sometimes there are reports in spinal cord injuries, also in stroke, but at the end is a phenomenon that we see in amputees. So if the impact, the importance of the visual feedback is so low, why do we not see the same phenomena in stroke, for instance, or in brachial plexus lesion, or in spinal cord injury, and so on?
Just to clarify, I'm saying that it's not fundamental for the relief of pain, and it's anthropomorphic visual feedback. So try to be quite precise on what kind of visual feedback. So visual feedback is, of course, very useful, and as we discussed, on learning motor control and being able to, in our prosthetic work, we can get somebody to differentially activate the short head and the long head of the biceps by providing real-time, visual feedback. So it's useful for that sense. Now, in my experience, and this is something that we have discussed before, Giovanni, there is many patients with nerve injuries and a stroke that report phantom limb pain. So the whole reason why I started working on a stroke and nerve injuries is because I got calls from centers around Europe, and we have done some work with those. So I haven't had the time. I was planning to hire a postdoc that at the end didn't come, so I'm looking for people if you want to recommend anybody. But I want to look at the epidemiology of this. So like, because you said that this is not the same, but I think many clinicians report it as it is the same. So I have met, both the stroke and patients with brachial plexus that say, they describe the phantom in the same way as an amputee, and they'll call it phantom limb pain, and the clinicians call it phantom limb pain despite that they have a limb. And there's always this disclaimer, like, well, it's phantom limb pain. They have a limb, but it's like phantom limb pain. So to answer this question, I think we'll need to look at epidemiology and see, the characteristics and the incidence of it to be able to roll it out.
Yeah, and I'll add sort of that, you know, we're obviously limited in the amount of time we had for our talk. So one of the patients that I saw at Walter Reed was a guy who had a motorcycle accident, complete brachial plexus avulsion. He had what we would consider phantom pain with a frozen arm, and so we tried mirror, and he was able to have partial relief. And then similarly with his mirror, as soon as we took it away, his phantom became frozen again. So somehow vision is helping with the movements. Max and I had a discussion sort of after our talks, and you know, I think that the jury is still out as to what role vision actually has in these therapies. Like, we found it was actually critical for our patients to have the visual feedback, that it helped enhance the effect of the mirror. Do you actually need it? And maybe you can just close your eyes and move things around, or sort of, I think that is still up for debate. The other interesting thing about our patient was that we actually could map hand onto face in him. And he actually had a nerve graft. And after he received his nerve graft, over about a month later, he said he could no longer feel his hand on his face. So he was checking himself at home after we raised this issue with him when we were working with him. And he reported back that clearly, like, he could no longer feel his hand on his face after the nerve graft really helped it sort of reinnervate him. So I think that, you know, many of these phenomena are probably reversible, depending on what interventions happen and how the course of the condition progresses.
So, and I will just add that this is an empirical question, right? So I haven't had the time to run, or not the time, the possibilities to run the study, but a study to test this will be, we do our stuff with virtual, an anthropomorphic visual feedback, and then we just do games, where there is no virtual representation that look like a limb, and I will. So based on what I've been thinking, the prediction will be that the improvement of pain will be the same. But you know, running studies with patients with amputees, it's time consuming. It takes a lot of time. That's why we're doing an international clinical trial. But that will be something that we are planning to do. And in our next therapy, we are relying very little on anthropomorphic visual feedback. So we'll test it. And if anybody want to run that study, I'm happy to.
No, it's like you showed with the driving the car, right?
Right.
I mean, that's, you're just moving the muscle somehow to drive the car around, and maybe that's sufficient.
And that's one of the
feedback. It may be like the talk yesterday about AMI, sort of like antagonist, the two, you know, the agonist antagonist being sewn together. Maybe that's why that works, is you're constantly pulling and pushing bilaterally and giving whatever feedback that way.
Right. So what I will say is that what I'm suggesting can explain why that will work. And why this will work. And even in our studies, the treatment is only one part with augmented reality, this anthropomorphic visual feedback. A lot of it is on games. But that's a question that we will test with experiments.
Yeah, we are running a lab experiment where we really look at the differential effects of visual and somatosensory and motor, and the combination. My hunch would be that the combination, of course, is best, and then every single modality will also have an effect, but may have not as strong effects, the visual as the somatosensory, for example, but it sure has an effect. I wouldn't say it's zero, but that can be empirically tested, in my opinion, and that's what we are doing.
And to be consistent, if what I'm saying is that we should try to engage as much as possible of the neural circuitry, definitely not limited to the cortex. And then, you know, the role of mirror neurons will play a role there. That's a part. You know, I don't know how. It doesn't look very big to me, but if we get all that together, then the likelihood for the therapy to succeed will be higher. So I'm not saying that it's entirely useless. My point, to be maybe a little bit more bold on this, was that shouldn't be the focus. Getting a virtual reality environment that looks exactly like a hand and moves exactly like a hand, then you just use a mirror. So I want to, you know, just say that that part shouldn't be the main focus of the therapy, because the evidence to suggest that is not
So
there.
we in an experiment we're doing with healthy people, where we try to reverse the effects of immobility on a limb, both on peripheral, like muscle mass, but also on brain changes. We see that just passively watching the movement in a video has much less of an effect than actually, you know, doing it in a virtual environment. And what Thomas said, that it doesn't matter if it's the affected or the unaffected hand, that's true. So since we have so much activation you know, also ipsi and contralateral when you're doing movement. That's not so important, but just the passive versus active seems to be a big thing.
And I will say that maybe the approach of graded motor imagery, it can be useful for some patients that have like entirely frozen phantoms and psychological, more psychologically severe problems on understanding their missing limbs and so on. So started slowly in that kind of way will be beneficial for those patients, but maybe not for others. So there are most of our patients are entirely comfortable sitting in front of a computer and seeing their a virtual representation and moving them. But we have had a couple of cases where it was a strong experience. And at that point, you know, I would say, well, we should probably start with maybe graded motor imagery with these patients because the psychological factors there that are important to consider.
Angelo, do you want to comment?
Yeah, I just wanted to comment on this. Well, of course, vision and motion are two aspects of this story. So for sure, if you use a mirror box, the more, I mean, the visual input is similar to your phantom sensation, the better, at least the faster the effect is in rehabilitation, or at least the easier for the patient is to perform the exercise. But of course, also motor programming is such a powerful way of increasing, you know, any sense of ownership for the phantom that, of course, can be effective by its own. So I think that these are just two aspects of this story. And but I just raised my hand because I wanted to make a general comment and maybe ask for maybe Herta Flor and Tamar Makin for a comment, because I keep on reading their works, which apparently have some differences in the results, but I keep on liking both of them very much. So the same, so I cannot decide which I like more. So I would be very interested in understanding the real nature of the differences in your results, whether it's methodological or it's just maybe more on the way in which, for example, the tasks are just asked to your patients. So the amount of movements which is requested, the type of sensory stimulation, and also I like very much the well, the idea that was shown by Herta Flor, I think, of your common work, in which a large network of areas is actually seem to explain, you know, the nature of phantom limb pain. And I think it's an old story, this, because in the early 20th century, when neurologists and neurosurgeons struggled to find the locus, the cerebral locus of pain, they couldn't find it because it was not on somatosensory cortex. It was believed it was in the thalamus, but then it comes out that it's a large network involving many cortical areas, subcortical structures. So, of course, it's probably in that direction that, of course, we will find a more general definition, anatomical definition of what phantom limb pain is. And so I just wanted a comment from you on this issue. It's not provocative. It's just
no. I'm very happy. I'm very happy to go first.
I really like your work a lot, so I just want to decide which I like more.
I can tell you that off the record, I agree with Herta strongly on almost all issues. I think, you know, the take-home message from her talk today was that, you know, we have to consider phantom pain and its origins from a much larger scale than S1. I couldn't agree more. I think personally, we're wasting valuable time working on S1, where we need to think about, you know, what used to be called the pain network or the pain matrix, or areas that we know are related to modulation of pain. And I know Herta is on the same page with me on that one. And I think, you know, Herta agrees with me that plasticity can be driven by multiple mechanisms. She said it in a talk as clearly as I did. So I think conceptually we are pretty much 99.9% in agreement, where we potentially less agree, and Herta can correct me, is whether S1 reorganization provides a good heuristics to what we see is happening in the clinic for phantom pain, both for manifestation of pain and in the clinic. But I think we both very clearly said neither of us thinks there's a causal relationship between either persistent representation and reorganization and driving phantom pain. But I don't want to speak too much on behalf of Herta, so please, Herta, correct me if I'm wrong.
Yeah, no, I think I agree with most of what you said. I think the tasks, though, make a difference. If I use passive sensory stimulation, I have a quite different type of stimulus that goes into the nervous system than if I use phantom movement. And to understand what are the differences and the similarities in the results we get with these two different types of probing the system, I think it would be one interesting part. The reason why I still am interested in S1 is that Ken Shalom many years ago in the monkey showed there are nociceptive neurons in S1. And I think it has been replicated also by other people, but they are very widely distributed. They are very differently distributed than the non-nociceptive neurons. And so I think there is a possibility of a contribution of S1, but as you said, in a wider network, definitely, and not only by itself. And yeah, that's what I would say about that.
So can we get excitation of pain from a stimulation of those nociceptive neurons in S1?
Well, since they are widely distributed, and if you do a stimulation in a certain area, I'm not sure if you will really get enough activation that you really can create a painful percept. Though there are some studies where people try to dissociate painful and non-painful sensations in S1, and there are some studies that suggest that this is possible. So I think there is a nociceptive network also in S1, but it's not as easily maybe detectable or modifiable as other things. And I agree definitely with Tamar that this is can only be one aspect of a wider network, as I have also shown.
Does the role of the cortex or S1 in particular go beyond localization of the experience? Is quality to be not to be encoded in the cortex, or like can we say that the cortex plays a role on the quality of the talk, or is it? I mean, it certainly localizes it, but what else can we say today of what we know about the cortex?
Well, I think we need the cortex. The question, I think, should be more S1. Is it S1
Okay.
or is it the insula? We know that the insula plays a very important role, for example, in creating the painful percept. So I think there are multiple areas. And of course, what we see in the cortex can originate from the spinal cord and come through the brainstem and the thalamus, as we heard. So, but this is kind of the final end result, I think we see, is in the cortex, and multiple areas contribute to it. Especially with phantoms, of course, parietal cortex has a really important role in giving you the percept. And if you can disturb it by stimulating there or inactivating neurons, so I think it's a complex story of interrelated networks, which we have to find out.
Right. Can I just chime in on the role of S1? This is Sleeman up here.
Oh, hi. Sorry. I keep staring at those cameras.
So one of the things that I think a relevant data point here is, coming from a neuroprosthetics, ICM, intracortical microstimulation world, we have stimulated monkeys and humans thousands and tens of thousands, hundreds of thousands of times, and have never once elicited a painful sensation through intracortical microstimulation of S1. So I feel like when you're talking about the role of S1 in pain, I feel like that's a relevant bit, right? Just to think that, for example, it is part of a pain network. Stretches, it interacts with pain networks, but I don't think you could think of it as a part of a pain network in that it doesn't seem to be able to, you can't elicit a pain sensation there.
But the characteristic of a network is that you need the network, so I would argue that.
But you can, you get tactile sensations, but you
Yeah.
just never get nociceptive ones, right? Anyways, it
yeah, I
seems
guess
relevant.
so I guess that's my point. It seems like it's relevant for tactile sensation. But the other thing is it, because now this can go deep, but I mean, pain is a conscious experience. So consciousness is relevant for all this. And there's a lot of discussion whether the cortex actually plays any role on consciousness, and maybe everything comes from the brainstem. So is it, and so my argument will be, what is the evidence to say that that the cortex is not only the last step, as you suggested, of something that is informed and happening, and it is a fundamental part for the experience of pain to exist. Going back to the argument of, they had animals that removed the cortex and behavior seems a bit similar and so on. So do we really know that the cortex is essential for the painful experience?
You cannot wipe it out and check it, right?
Well, I guess in animals they have done the prevalent pain models of pain in animals.
Well, when you think about stroke, right, supernumerary phantoms, right, it's not necessarily cortical, where you can perceive the supernumerary phantom.
But that's again goes so to make that's
right.
It's not
stroke-related pain is
okay.
subcortical. Is typically, you think of thalamic pain syndromes, like when you have small vessel stroke.
Right. So that will go in favor of my argument. That is maybe brainstem and
right.
not the
well,
cortex.
I mean, consciousness, right, is reticular activating system. That's not cortical.
Right.
Right.
Right. So I think the cortex has received a lot of attention, and but I'm not sure is where we're going to find the answers beyond reflections of what happens, maybe a little bit below.
For cortex, you mean S1 or M1, so primary somatosensory cortex.
I think I will take the whole cortex, really.
You meant the whole, right?
Yeah.
Because the whole cortex,
but I think it's an
Angelo, please go ahead.
No, sorry. No, it's an old story in neuropsychology, this one. I mean, there are very clear neuropsychological syndromes, such as the somatoparaphorenic beliefs in neglect patients, that are probably, I mean, in many patients, they are just coming out from subcortical lesions. But this does not mean that cortex is not involved. I mean, it's just connections between areas, which may be critical to consciousness for some functions. So you can either find those syndromes with parietal lesions, but also with subcortical lesions. And this means that it's very important to keep on studying networks, but not because cortex is not involved. It's not involved as single areas. I think.
Right. So
and then
go on.
So, no, just to and then having, for instance, in tactile perception is an higher order compared to primary sensory cortex. So when you have the N20 in S1 for a tactile stimulation, proprioceptive stimulation, you are not already aware of the tactile stimulation. So you need more elaboration in the cortex. And so for consciousness you need cortex. This does not mean that the brainstem is not important in consciousness, because of course the brainstem is supporting the whole cortical activity. But S1 is an intermediate step to have consciousness about tactile or maybe not nociceptive stimulation, but of course tactile stimulation.
I think the discussion on consciousness can go for a lot longer. We run out of time. I think this was very interesting. I apologize if my communication hasn't been very clear. I'm not meant to estimate the work of people and so on. I'm just asking questions, and sometimes I just ask them a bit rudely. But
sure.
Thank you for everyone who participated today. And this discussion will continue tomorrow, or probably there's going to be more surgical stuff. So we'll be happy if all of you can join us again. And
And I'm also looking for a postdoc.
Yeah,
or two.
too.
So am I.
So I'll put a plug in for our labs.
Call in the left to right hand direction, please.
Advertisement.
Okay. Thank you, everyone, and we wrap up this session. Bye.